Healthy Schmelty.
Hey there, I'm Rishi B, and welcome to Healthy Schmelty, the fancy schmancy podcast where each episode I share wellness info I've learned, or share general info I've learned. Now, I'm no hoity-toity professor, but I am a master of public health, and I like to be armed with knowledge. Don't you? This episode, I share my interview with the PhD and nurse Teresa Brown, who wrote the New York Times op-ed, The Real Problem with the Healthcare Bill, which is about the American Healthcare Act, aka AHCA, aka Trumpcare. Her op-ed discusses how both the Affordable Care Act, aka the ACA, aka Obamacare. You know what? You people need to stop with all the nicknames. I'm calling it the ACA. If you have problems with that, well, you can get out. Anyways, Teresa's op-ed, The Real Problem with the Healthcare Bill, discusses how both the ACA and the AHCA address two different problems in healthcare using two different strategies. Teresa wrote her op-ed soon after the AHCA passed Congress. The bill is currently pending Senate approval. Before the interview, I just wanted to make sure everyone's on the same page about both the ACA and the AHCA. In particular, I just want to make sure we're all on the same page about what both of these bills do. The ACA was the first major healthcare reform since the 1960s, and its goal was to guarantee everyone quality insurance despite the cost. Its key components were stopping insurance companies from denying coverage based on pre-existing conditions, a mandate on all citizens to obtain health care or else pay a fine. The ACA also expanded Medicaid by lowering the poverty line and offering Medicaid subsidies to states. The AHCA bets that increased profits in the healthcare industry by having the sick pay more leads to increased quality, thus reducing costs. It removes the mandate, moves the individual and Medicaid subsidies to younger people and also people earning greater than $200,000. The AHCA also allows insurance companies to deny coverage based on pre-existing conditions and allows states to waive coverage guarantees as long as they have a high-risk insurance pool. The government will give $138 billion over the course of 10 years, that is after the AHCA passes, if it does. And so the government will offer this money over the course of 10 years for these high-risk insurance pools, but no details on what the pools have to be or any details on the pools at all have been released yet. Okay, that's enough homework. Here's the interview. So I'm talking with Teresa Brown. She's a registered nurse and writer who is the author of The Shift, 1 Nurse, 12 Hours, 4 Patients' Lives. Her writing also includes the New York Times op-ed, published soon after the AHCA cleared Congress, The Real Problem with the Healthcare Bill. And this op-ed is what brings her and I here now. Teresa, thank you very much for joining me today.
You are very welcome.
So how about we get into your background first? I think I saw online that you're a nurse at a hospice. Is that correct?
Yeah, so I worked in hospitals for several years and then made the switch to home hospice for a lot of reasons, but I really wanted to see patients in their homes because I feel like we never see people at their best in the hospital. And I wanted to see patients in an environment where they were more in charge and, you know, surrounded by their staff and their family. And it's great. They're really like so much fuller people in a way in their home.
Yeah. So have you been nursing for a while?
About 10 years now, I think. Yeah, so my background, I have a PhD in English and then taught for 3 years at Tufts and then decided, wow, I don't think this is the job I want to do. And and then had kids and had a friend who's a nurse who directed me to nursing, and that was it. So. Oh, great. And if you don't mind me asking, was the shift to the home hospice, was that relatively recent then? Yeah, about 3 years ago. Yeah.
Okay.
I'm really bad at keeping track of time, but everything kind of.
that's really interesting. You found the home hospice like a bit more engaged with the patient then.
Well, but they
right.
just have a lot more control. You know, in the hospital, It's come in and wear this gown, and we're going to tell you when to sleep and when to wake up and when to eat, and people are going to walk in and out of your room at all times, and sometimes they'll introduce themselves and sometimes they won't, and just take away people's privacy and sometimes their dignity, and
sure.
And it's all, it's none of it's done maliciously, but I feel like it really is hard on people. And so I wanted to see what people were like getting healthcare in their homes, which has other challenges, right? Like if it's
sure.
the patient is elderly and their caregiver is also elderly, well, you don't have aides and nurses who can come in and help get you cleaned up and give a bath and
right.
change the linens and all that stuff. So it's not like there aren't challenges and trade-offs. There definitely are. But just in general, people seem more like themselves at home, which
sure.
I guess is not a surprise.
Yeah. It's interesting. The hospital system that I work for, well, we'll see what happens with this new healthcare bill, whatever happens, and even if the current administration is around to see their healthcare bill get passed. But
right.
So the hospital system I work for, they're trying to transition all their care to a more risk model incentive basis with providers, and towards that goal, they actually recently started looking into providing more home care services. And,
wow.
So they find, so I forgot which state it's in, but one state did really well and like very significantly reduced the costs that are like inefficient service and stuff like that, unnecessary service. They greatly reduced all that kind of stuff by increasing their home care services. So now the hospital system was looking into getting into that. I think that might be a little bit on the edge now with the new healthcare bill and wherever that goes. But
but that's a great segue actually into the healthcare bill, because
absolutely
that's the point I was trying to make in my New York Times column was we're looking at this in such a rigid way, and there's so much waste, which people love to talk about. Oh, we get rid of the waste in healthcare, we fix our problems. But my feeling is there's so much monetary waste because there's so much money being just stripped off into profits because we believe in having a for-profit system. But then you're talking about, oh, look at this innovation. We could reduce hospitalizations. We could really reduce all kinds of costs by shifting the workload around and thinking differently about what do people need to stay in their home. And that has everything to do with making care better and also saving money, but is not about, well, who's going to get rich off this? And I think the public just doesn't understand how many people are getting really rich off healthcare and how much the system is now set up to enrich certain groups of people.
Yeah, and actually, to your point, I found a note that I thought you might find interesting that goes to this. In 2012, the Institute of Medicine noted the 6 biggest factors contributing to excess healthcare costs are unnecessary services, inefficiently delivered services, excess administration costs, prices that are too high, missed prevention opportunities, and fraud. So those 6 factors are contributing the most to healthcare costs. And arguably, everyone besides the prices that are too high are dealing with, quality of care, basically. And I think what you're saying is absolutely right. The basic economic model, the basic economic, like how we understand prices and the give and take of a market. I don't think that applies to healthcare because, hospital systems and insurance companies, it's not so much like, I guess it is to some extent what we charge a person and what we get, but it's almost like how can we adjust the scales a little bit so that we're getting a little bit more out of that. It's not so much, I charge you this price, this is what you give me. It is to some extent, but I think there's like a kind of a balance there that they're trying to tip more towards their favor. I don't know if you would agree with that. Yeah,
I would. And does the average person know, for example, that when you go into the hospital or even in some home care settings, but I think it happens a lot more in the hospital, that there are people whose job it is to make sure everything that's put in the computer or the billing system relevant to your care is done in a way to maximize the reimbursement they get. And and that might not sound like a big deal, but it's, millions and billions of dollars probably that go into paying more when the care is probably in a lot of ways just the same, but it's how the diagnosis gets coded. But then also there's people who are being paid to make sure all the most lucrative codes get put into the computer. And, that just kills me that we're paying people to make money off healthcare instead of to take care of patients.
Yeah. I pulled a bunch of quotes from your article around this, around what we're talking about. I think the one that, profit and quality of care don't go hand in hand. So you were saying government programs working with our, and by the way, for the listeners, I'll have a link to Teresa's op-ed, which was published, I think that was May 4th, in the New York Times. But a quote from that is that government programs working with our existing structure of for-profit insurance companies can expand and improve coverage, like the Affordable Care Act, or offer lower insurance premiums, like the new Republican plan, but they can't do both. I think that's really important because, the big point that you're saying in your article is it's not so much that the ACA and the AHCA oppose each other. It's almost like they're, I wish I pulled this quote, but they're addressing two different problems. So they're playing two different sports. They're in the same sport, but they're, I don't know, one playing squash, one playing racquetball, something like that.
Right. No, that's right. That's a good metaphor.
Yeah.
I think, That's exactly right. So the Affordable Care Act wanted to give more and more insurance to more people. And then the American Health Care Act, the new Republican bill, wants to make insurance cheaper, which, just so people know, they're really doing by having insurance cover less,
right.
Yeah, which a lot of people say is what they want, and that's fine until they, like I said, get in a car accident or wake up and have leukemia or go ahead. Neither plan is really trying to rein in profits. The Affordable Care Act has some things in place to do that, but mostly the profit-making ability of the businesses in our so-called healthcare industry was not touched by the Affordable Care Act.
Just a local anecdote. So I live in Michigan, and the major healthcare insurance provider here is Blue Cross Blue Shield of Michigan. And as part of the Affordable Care Act, Blue Cross Blue Shield of Michigan, so they had a not-for-profit status and a tax-free status, which I think a lot of people could argue they were taking advantage of. So after the Affordable Care Act, they got a not-for-profit mutual status, and they had to donate, or not donate, but they had to give, I think it was around like 10 billion or something over the course of 10 years towards public health initiatives in Michigan. So, so while at the one hand, it doesn't completely get rid of that healthcare profiteering that you're talking about. Mm-hmm. On the other hand, they did do some things to, I think it wasn't so much to reduce the profiteering, but it was more to make sure that there was no monopolies and that there was an open market, which, that does to some degree does address the profiteering.
Right.
Maybe not to the full extent, but.
Right. But no, I completely agree with you. And making the switch from fee-for-service to value-based payment. So if your listeners don't know what that means, and all these terms are so complicated, I think that's the other thing.
Yeah.
People just kind of zone out because they don't know what the words mean, and it's hard to follow. But fee-for-service means I go to a doctor, the doctor fixes my broken leg, and then she bills for the visit and the x-ray and the casting, whatever. So whatever service you get, there's a fee for that, and each individual thing gets paid for separately. Value-based payment models mean I break my leg, I go to the doctor, and the payment comes more in terms of how the care actually went and was my leg fixed. And I mean, this probably is not a good example, but just to say that it's looking at outcomes rather than just every single thing that a physician does gets reimbursed, right? No matter, if the doctor sets my leg and my leg is crooked, well, the doctor still gets paid, and then I have to have my leg reset, and then the doctor gets paid again.
Right.
So a value-based system would not pay for both of those castings. So that's always struck me that, say you have an operation and then you get an infection and there's something that goes wrong and they have to go back in. And it's not that that's anyone's fault necessarily. It might be, but it might not be, right? Bodies are very complicated. But then the bill just goes up and up and up. Whereas if you go to your auto mechanic and they replace your carburetor and they do something wrong, they can't then charge you again for doing the same thing. It might be that there was something wrong with the carburetor they put in. It might be that there was something more complicated about your car they didn't realize, and that you're going to have to pay for. But the whole idea of if healthcare happens and then there's a mistake and then you pay again and again and again, that it's not that it makes people make mistakes, but it's just a very strange model. Mistakes are going to happen, but, right. Right. But instead of having a system that just says, no matter what happens, we pay, it's better to have a system that says, let's pay based on trying to reduce the mistakes and the bad outcomes. And then, of course, we'll pay for the things that nobody can control, but let's at least try to control some of these things.
Right, and I think that's a great example with a car. So that's what the ACA was trying to get at, whereas the AHCA, at least in its current form, is more leaning towards the fee-for-service. You pay for what you need. Let's get into that in a second, but let's talk about what the ACA didn't do. So the big gambit, I guess, for lack of a better word, with the ACA was that if we mandate everyone get insurance, meaning if they don't, they have to pay a fee. If we do that and we make the markets in every state more competitive and have different plans in a healthcare exchange, then everyone's going to get healthcare insurance. And this will buffer the people who preferably everyone would have insurance, but this would buffer some of those emergency costs and people who aren't insured, getting very drastic care only when they really, really need it. This right. would buffer some of that because a lot of people will have insurance. So, I mean, as it turned out, because the ACA came out in the 2010, as it turned out, I mean, a lot more people did get healthcare insurance, but turns out it wasn't enough really to, cover that goal that ACA had. Would you agree with that, or do you see it differently?
Yeah, well, yeah, it actually, the great thing about the bill is it did slow the cost increases more than they had predicted, and the overall expenses of it were less than predicted. But at the same time, I know that premiums were rising in a lot of states, and yeah, then you get a problem with younger people feeling like I don't need this, or truly I can't afford this. I'm in my first job and I just can't pay this and pay my rent and pay off my student loans and, all those other things that millennials are having to deal with. So,
I feel fortunate in a way. Maybe my view is skewed because I'm fortunate enough to have healthcare insurance through my employer. Maybe I just don't see it from the angle, because the people who complain the loudest, as just based off of what I've heard anecdotally, were people who had small businesses and older people whose premiums were increasing. But maybe because I'm fortunate enough to have healthcare insurance through my employer, maybe I just don't see it through their eyes, that it's more important that you do have healthcare insurance than you don't. Because just from a economic perspective and a public health perspective, the best way that I can guarantee you that your care is better is if you get healthcare insurance. Just having healthcare insurance improves your the likelihood of you having better healthcare as a person.
Right. Yeah, right. And then, and that gets into what you were saying at the start about ideology, at least somewhat. I think I was talking with someone who was complaining about how much a friend of hers was having to pay, and she doesn't even use it. And that's the conundrum that makes me so frustrated, that people don't understand. Yes, you're not using it, and you can look at that as just throwing money away, or you can look at that as you're paying into the system so that if and when you do need it, it's there for you.
Right.
But that, I don't know what it is that people can't get that. And to me, it feels like ideology. Why should I have to be paying for something that other people are using? I only want to pay for myself. And if you say to people, well, look, if you got really hurt, if you got really sick, unless you're really rich, there's no way you could pay for that yourself. And somehow they just don't absorb that. I find it extremely frustrating that it's so hard to get people to understand that, when in every industrialized country around the world, this is what I started the column with, people pay less for healthcare, and in general, the healthcare is better. And, everybody pays in, everybody does better. Okay,
so that's a perfect segue to the AHCA. So just to wrap up with the ACA, they tried to open up the market, and ultimately they lost a court case. I think that's where it went down, where it allowed states to kind of have more flexibility in what they had to do. And in some ways, that was almost the undoing, I think, as it turns out, to the ACA. So part of the ACA was that every healthcare plan had to have minimum benefits. Am I saying that? Essential minimum
the 10 essential benefits, right?
Exactly. Yeah. And so even though prices were going up, if you have healthcare insurance, you had certain guarantees of what you were paying for. And I think that kind of segues to the conservatives and the bill that they proposed, the AHCA. which I think, just as a side note, is a little joke that I saw. So forgive me because it's a bad joke, but I saw that the ACA, the Affordable Care Act is known as the ACA, and then American Health Care Act is AHCA. It's almost the same thing, except they added an H to the acronym, which is very appropriate because it's almost like the Affordable Care Act, except they got rid of all the guarantees and they added the high-risk pools. So that's what the H stands for.
Okay.
Really bad joke. I'm sorry. They're focusing on the cost aspect, and so to reduce the cost, they got rid of all the guarantees. Like every healthcare plan, you're going to have those 10 essential benefits, and you no longer have to have healthcare because they got rid of the mandate as well with this bill. So, and your op-ed, basically, the basic crux of your op-ed is that, like, they're focusing almost on, they've almost completely lost sight of the care aspect of healthcare, in a way, right?
Yes, and I think people got upset about, well, why should I have to pay for addiction treatment? Or there were all these men in Congress saying, well, why should I have to pay for maternity care? Why should I have to pay for mammograms? And of course, the point that someone did give birth to these people and, needed help with that. I mean, it's just, I feel like it's American rugged individualism taken to this extreme, but also sexism and misogyny, because it's all men saying, why should I have to pay for these things that women need? But right, the idea is if you strip off some of those 10 essential benefits, insurance will be cheaper. And of course, again, that's true. Of course, one of those essential benefits is hospitalization. Another is emergency care. And you can pay $12 a month for insurance if all it covers is giving you a Band-Aid. But if you need hospitalization and it's not covered, unless you're going to choose to stay home and die, which seems like a horribly stupid and sad choice. Yeah.
Oh, I'm sorry. Well,
somebody's going to have to pay that bill. Yeah.
Exactly. And it's really sad, but, unfortunately, because of the pre-existing condition aspect of the AACA, where they got rid of basically the whole thing where insurance companies can't deny you coverage because of pre-existing conditions. I saw that the Congressional Budget Office's analysis of the first draft of the AHCA, they predicted that there's going to be more uninsured people because all the subsidies and benefits that are now going to the poor and the more sick, which tend to be older people, since all of that is going away from them, older people are probably going to opt out from having insurance. And so, sadly, in a way, what you said is almost exactly right. They're just going to forego having insurance because it's too much money, and they're not going to go into the hospital until it's too late, and
right. And if we were a poor country, if we were struggling just to stay afloat economically, if we had a food shortage, if there were things like that going on, but there's people buying $30 million apartments in New York City and people with 5 very nice homes and private planes and buying extremely expensive clothes. And, there's lots of money in our economy that's going to pleasure and disposable income, and there's nothing wrong with that. But we have the resources to make healthcare affordable for everyone.
Right.
We
and
just choose not to do it.
And, like I said, the subsidies and the tax benefits. That's all going to young people and rich people basically now with the AACA. And it's that old, the old trickle down theory, which I don't know how that works in healthcare. Younger people and richer people having healthcare won't trickle down some juice on me
right.
to get their healthcare benefits. So I don't understand that logic. But
it's scary. I mean, I have really good insurance through my husband's job, but what if we lost that? It's really scary. And it's not that I want people to be scared, but I want them to understand that your health is your body, is your life, and you only get one life. So
right.
You want, like what you said, the better insurance you have, the better care you're going to get. That means the better your health is, the better your body is, the better your life is. It all goes together, and this is not something new age. This is truth, and I see it every day in my work. And I wish people really got that, and there would be a movement for, let's have health insurance for everybody because we all deserve that.
Okay, that was my interview. My many thanks to Teresa Brown for her time. Her op-ed, once again, that's in the New York Times. That is The Real Problem with the Healthcare Bill. And her book is called The Shift, 1 Nurse, 12 Hours, 4 Patients' Lives. And I'll provide links for both of those in the show notes for this episode. Before I end this episode, I just wanted to share a couple points about where the Affordable Care Act failed. So healthcare spending as a percent of GDP in general since the bill passed has gone down. However, in 2015, healthcare spending as a percent of GDP rose to an amount that hasn't been seen since recessions. The economy was doing well, so it buffered this increase. And once again, in general, healthcare spending has gone down since the bill passed. That's just a bullet point of spending in 2015. Premiums since the bill passed are set to go up 25%. That is if the bill doesn't pass and everything with the Affordable Care Act was left intact, which may or may not be the case. It depends on where this White House administration goes. And so the subsidies that are currently offered for healthcare would not be enough for most Medicaid participants. So as it turned out, the big bet with the Affordable Care Act was that a lot more people than they did before would buy healthcare insurance. And by a percent, more people did. However, it wasn't enough. And it turned out that the mandate fee was not large enough to provide most people an incentive to buy healthcare insurance. Also, healthcare insurance companies, have dropped out of exchanges in many states, which increased the prices even further because there was reduced participation. States that didn't participate in all the Medicaid rules in the Affordable Care Act and who also have a larger percentage of poor people who weren't receiving the subsidies because the states opted out. These people, they spent more out of their pocket for healthcare insurance than other states. And also the state flexibility in whether they wanted to participate in Medicaid, that turned out to be a general weakness for the Affordable Care Act. So it's pretty clear further reform is required in healthcare. No one's saying it's perfect. However, based off the experiences with the ACA, it's pretty clear that the issues with healthcare are primarily where there's too much flexibility, like the profiteering Teresa talked about. For further reference on this, I highly recommend an episode of Last Week Tonight with John Oliver, where they did a deep dive into the kidney dialysis industry. You can find a link to that in the show notes. Based off initial analysis of the AHCA, Its major weaknesses all surround where it's giving even more flexibility than the ACA. So, as it turns out in healthcare, having guaranteed quality medicine is the most profitable economically.